Welcome, and thank you for joining EPA's webinar, Solutions for Supporting Healthy Children Managing In-Home Environmental Asthma Triggers During the Pandemic. The panel will begin shortly. As you join, let me familiarize you with the GoTo platform and our plans for today's discussion. The audience will be muted throughout today's webinar, and this event is being recorded and will be posted on asthmacommunitynetwork.org in the coming weeks. Today's webinar is scheduled for 1 hour. Towards the end of our scheduled time, panelists will take a few minutes to field attendee questions. The audience can ask questions by using the question pane in your attendee control panel. Immediately following our presentation, you will also have the opportunity to ask questions and interact with our panelists in the discussion forum on asthmacommunitynetwork.org. You do not need to be a member to participate, so please follow the directions here and access the discussion forum. Asthma Community Network is also where you'll be able to access the archive of this webinar and all previous webinars EPA has offered regarding asthma. Please join me in welcoming Kate Hastings as the facilitator for today's panelist discussion.
Thank you, Pierce, and welcome everyone. Thank you for joining us for a conversation with some members of EPA's Asthma Community of Practice, a group from across the country leading policy change to finance in-home environmental interventions for asthma through healthcare reimbursement and other avenues. My name is Kate Hastings, and I am the facilitator for EPA's Asthma Community of Practice and today's discussion. I have been very lucky for the past 20 years to have the opportunity to learn with this brilliant and generous group of health leaders and their US EPA hosts, as we have all championed solutions for the environmental determinants of asthma. I am really excited to share our group with you today. Our panelists have deep experience in clinical asthma care, community-based care and services, in-home care and environmental interventions, and healthcare and environmental policy. I want to take a minute to describe this group so you have an idea of the incredible mix of knowledge and the breadth of experience represented here today. Let me start with Anne. Anne Kelsey Lamb is a policy leader from California, and at the Regional Asthma Management and Prevention, or RAMP, where Anne is the director, she unites and activates networks of leaders statewide across public and community health, healthcare, and environmental fields to expand healthcare financed in-home asthma care that includes environmental interventions and is delivered with asthma home visitors. Anne has led statewide coalitions driving system change, and she is helping to address asthma disparities by paying for patient-centered care delivered at home. Since 2020, a $15 million legislative allotment in California has supported a pilot program for asthma home visiting services, where they are testing high-value solutions for possible statewide adoption through Medicaid or other financial sustainability avenues. Anne brings all of this experience and her multidisciplinary perspective to our conversation today. Welcome, Anne. Ellen Tone is a renowned energy, public health, and policy expert, and she has experience at the local, state, and federal policy and program level, as well as a long history with non-government organizations, foundation, and utility industry programs. She has worked across sectors and nationwide to deliver environmental asthma interventions and broader healthy home services, from helping to design programs that include environmental interventions to finding ways to pay for them and connect improvements in built environments to improved health. Ellen is also a long-serving advisor to federal agencies on healthy homes and energy, and she has been a leader in programming and policy across New England and nationwide. Ellen also has truly remarkable experience in buildings of all types. She has been in crawl spaces, basements, attics, looking for energy and health risks and figuring out how to address them comprehensively. Thank you, Ellen, for joining us with your unique and really broadly informed perspective. Dr. Tyra Bryant-Stevens is a pediatrician and pioneer of clinical and community asthma care that improves asthma for all children, including many with disproportionate burden who are served by the Children's Hospital of Philadelphia, or CHOP. Dr. Stevens has built a community health worker and clinical care team partnership at CHOP that addresses patients' asthma care needs in coordination between clinic, community, and home. Dr. Stevens has championed care that includes environmental trigger mitigation and culturally appropriate services directed by a clinical team. Dr. Stevens is a tenacious and creative champion, and this is really exemplified by the fact that today, when her patients need it, CHOP's Community Asthma Prevention Program can pay for and is partially reimbursed with healthcare dollars to deliver deep in-home environmental interventions. And this is for many hundreds of patients annually at this point. Policymakers and providers worldwide learn from Dr. Bryant-Stevens and her CHOP policy and clinical teams what great asthma care looks like, as have most of us on this call today. Thank you, Dr. Stevens, for being with us today. Completing our team is Kevin Kennedy. Kevin is an environmental hygienist and director of the Environmental Health Program at Children's Mercy, Kansas City, which is an exemplary consulting, case management, research, education, training, and analytic service program. Children's Mercy and Kevin have been at the forefront of in-home environmental asthma care and practice, having helped to both develop and translate into practice evidence on the role of the environment in chronic disease. Kevin is also considered a national expert on environmental health and housing, and he recently served as the primary author for the first edition of the Building Performance Institute's Healthy Homes Principles Reference Guide, which was published in 2020. Thank you for joining us and sharing your experience, Kevin. Pierce, if you'd like to bring us all in group. Today, we invited this wonderful panel to share what they have seen, heard, and done over the, are we all live there, Pierce? To address environmental factors in asthma during the COVID emergency. Welcome, everybody. Nice to see you.
Good afternoon.
Now, good afternoon. We're across the country here. We've got west to east, the whole country represented. So late good morning and good afternoon, and hopefully not good evening for anyone yet. I want to offer just a little context before we get started in this conversation. We're really going to talk about environmental health after COVID and what have we all learned, what do we think is coming, what would we like to see come, and what have we seen succeeding so far. A little context for all of us on this call. You know, COVID-19 has really underlined some facts that environmental health has always known, right? That the environments we live in can help us to stay healthy, or unhealthy environments can make us sick. COVID, I think, has reinforced and amplified inequities we know from asthma. Disparities in COVID look a lot like disparities in asthma outcomes. And we're in a time here where doing the business of environmental health to protect people from environmental risks is perhaps more important than ever, and it may be harder than ever for us to see people face to face to address those risks. So I'd like to talk to you all as we reflect on stay-at-home orders, closed businesses, closed schools. You know, what are we doing to help mitigate the serious effects of environmental risks for patients, clients, and communities? And how can we share the best of what we've learned, think about what we got to be careful of, and spread what's working? So to start with, I'm curious, you all work in very different places, and but you're all involved in helping to manage the environmental triggers in asthma. And I'm curious, over the last year or so, what changes in like rules, requirements, what you're allowed to do and how you do it have you made so that we can help to manage the environmental triggers? What policy changes have you seen that have helped make trigger management possible, or at least some mitigation possible, even now? And I'm going to start with Dr. Stevens, because we'll start with clinical environmental management and then think about how does a full team complete the work. Dr. Stevens, can I start with you?
Sure. When the stay-at-home order came, at least for Philadelphia, which I think was close to the same across the country, I was actually on my way out of town on vacation, and needless to say, I spent most of my vacation trying to figure out what to do next. My first concern really was the 300 patients that we were following, or more, at least 300. And the prediction was that with asthma or any chronic lung disease, that coronavirus perhaps might be worst experienced through those populations. So staying at home was really important, but we also want to make sure that home was a safe place for them. And so our team of community health workers actually called all of our patients, and we made sure that they had everything they need in terms of medications, in terms of connection to their providers and answering their questions. And we heard a lot of things about the fears they had. And so we really wanted to make sure that we could still do our community outreach and our home visits. Being a primary care physician, I heard right away that we could still do telehealth visits. So the policy and then the managed care agreement to pay for telehealth visits for clinicians happen, not right away, but fairly quickly. And so my question was, well, if we can pay for clinicians' visits, can we pay for our community health workers' visits? And so I've been working with the digital health team with our asthma population health stuff. So I kind of knew the people to ask and where to go. And fortunately, we were able to continue those and continue to get reimbursed. Right now, prior to COVID, we got reimbursed for our home visits, and our Medicaid managed care organizations with whom we had contracts agreed to continue to reimburse for our community health workers. So one of the concerns we had with our patients, though, was the home assessment that we all do in our work, and how agreeable parents would be for that. And it turned out that they were very happy to show with their camera on the phones kind of where to go in the home, where the typical home assessment we were able to do. So I'll just stop right there unless you want me to continue.
How about others? Just Anne, I see you nodding your head. Maybe you can jump in there.
Yeah, thank you. Well, to provide some context, in California, shortly before the pandemic began, the state launched a new initiative called the Asthma Mitigation Project, which is a $15 million investment in asthma home visiting services in communities across the state. And then the pandemic hit, which of course poses challenges for launching a new initiative, from simple logistics like training. Some of the funded programs were new and needed to train their staff. Some have been in service for years, if not decades, but hired new staff. And the trainings that they used to do were very hands-on, in-person training. So that all had to be adjusted to virtual, just as teachers across the country have adapted their curricula. Other challenges are things like where they plan to get referrals from. Many of them would get referrals from the emergency departments at hospitals or from primary care providers. And what we're seeing across the country is that ED visit rates for asthma have gone down during the pandemic, and families are largely avoiding primary care visits. So there were these kinds of challenges. Nevertheless, the programs and the community health workers and promotores working with the programs have been very innovative and proactive in making sure that their services reach the people who need them most. So they have not been doing in-person, in-home visits, but they've been doing a combination of phone visits, video visits, including doing the environmental assessment, as Dr. Stevens just described, with the smartphone and walking around the house. And then usually some masked outdoor in-person interaction, whether that's delivering educational supplies before the first visit, or the environmental remediation supplies at the end. There are even some cases where they realize that a client's really going to do better with in-person education. So they meet outside on the porch with masks on and sit 6 feet apart while they do their demonstrations and education. So they've been really impressive in adapting to these changing times and really working with the families to meet their needs.
Thank you. And Kevin, I see you nodding away, and I know at your hospital you've had multiple sort of layers of rule changes. Can you tell us a little bit?
Sure. Lots of complications like everybody else. Is certainly when the COVID hit and we had the work from home order, we were actively, as you've heard from the others, actively doing our work in homes and in communities. All of that had to shut down. And part of it, like everybody is hinting at, part of it was stepping back and figuring out how you're going to connect back with the families that you're trying to engage with and try to give them the effective asthma education in the home, and how are you going to do all these things. Like Dr. Stevens said, we are fortunate to have a strong telehealth program at our hospital that had a lot of published evidence to show the effectiveness of telehealth visits for asthma compared to traditional clinic visits. And the good news about our hospital is they had done a nice job of developing best practices for virtual visits. So proper etiquette, how to set up cameras, lighting, thinking about a conversation that occurs over the internet. You got to tell people who's in the room with you or not. You got to ask who's in the room with them or not. There's active questions you have to ask. They're just different from things that you assume when you're in person. So we really had to rethink our approach, and then we developed a protocol based on that, what our virtual protocol would be. And then we had to have a way to pilot it because we didn't have that familiarity with the technology either. So we reached out to colleagues and friends and did practice assessments. We even had folks from New York who participated shadowed on one of ours just as a practice. And we worked with some great folks at Omaha Healthy Kids who also were trying to figure this out. So some of us reached out to each other to try to figure out how we could work together. But we've completely took advantage of the strength of what was available at our program or at our hospital in order to get things in place. And then it was just the anxiety of the families. Were they willing to even interact with people? There still is a tremendous anxiety about what's going on with COVID, but also, they're all closed up too, and many of them are not working. They have a whole lot of psychosocial challenges, social determinants of health challenges going on now that they didn't have before, as well as trying to manage their child's asthma. So it's recognizing all of those additional things are going on and just being so much more patient in any way that you can interact with them.
Thank you, Kevin. I'm going to ask you to come back to some of those specific lessons learned for making these things work in a few minutes, and ask you to come back to that specifically. But Ellen, I wanted to see, was there anything you wanted to echo or reinforce that you've seen rules changing or requirements changing to make environmental management possible?
Yeah. So thanks, Kate. And great to be on the call with all of you wonderful folks that I've learned so much from over the years. I think I said this to you earlier, Kate, when we were pairing. I sort of feel like there's been this sense of urgent flexibility, right? We're in a pandemic, right? And there were things that actually people wanted to experiment with that were sort of out of bounds before. But because we're in this urgent thing, we've actually gotten more flexibility. People wanted to try virtual things, and it was difficult to think about reimbursement for that. And really, when this happened, it was like, just try stuff, you can get reimbursed for things, or if you're a grant. So I have the pleasure to work with 7 hospitals in New York State, the New York State Children's Environmental Health Network, coordinated at Mount Sinai. And 3 or 4 of those hospitals had been really interested in doing virtual home visits, and it just seemed really hard thinking through the billing departments. And when this happened, it was like, you can definitely bill for telemed and at certain amounts of time, 30-minute times, 45. So we're trying to figure out how much time and how much you can get reimbursed for. But there really was a sense like, go experiment and you're gonna be paid for that. So that urgent flexibility was enormously freeing, I think. It was kind of an unexpected benefit, I would say. The other thing is I live, as Kate said, in 2 worlds, sort of the health world, but I live in the energy world too, and the same darn thing was happening there. We're doing energy audits to do weatherization in people's homes, and they said, we'll never do it virtually. And of course, they had to do it virtually. And they learned, they also had rule changes that allowed them to get paid for doing that. And I think what happened in that context was they were stunned by, and I think this is translational to the health world, how much that virtual visit actually, in some cases, built trust more quickly than in person. Sometimes people are a little nervous about you coming to their house, but if I can control what you're going to see right away, then that allowed them to feel more confident going back. And the other thing is it was changed the hours in the energy program. People started to do virtual visits in the evenings on weekends because staff were kind of working crazy hours, and that allowed more people to be served. So I think those are some of the things that I saw, and I think so. I think there's a lot of flexibility about payment, both on reimbursement and in the 2 grant-funded programs I have an association with in Connecticut and Rhode Island, which did home visiting with community health worker models, as Ann was saying. They relatively quickly, I would say within 4 to 8 weeks, pivoted to virtual and kind of just threw a lot of spaghetti at the wall to see what would stick, and tried a bunch of different platforms. It was WhatsApp, it was, FaceTime, it was Zoom with HIPAA. It was like, let's just meet the clients where they're at. And I think they were also surprised at how well that went. I think there was a lot of anxiety about that. I wanted to pose a question to Tyra too, but go ahead, Kevin.
I was just going to
Well, I
mention that.
think a bunch of people want to pile on that. Go ahead, Kevin.
I just wanted to mention that a bunch of health systems, this stopped all their clinic visits across the whole health system. And if it wasn't for telehealth, financially, there would have been all sorts of problems. So because of that flexibility, it allowed our health system, and no doubt Dr. Stevens' health system, to quickly convert a lot of the clinic visits and routine clinical activity over to telehealth related activities. And a lot of departments had to learn telehealth practices, but quickly did. And for some of our clinics, they recovered 80% of their clinical activity just by doing it virtually. So it was a real lifesaver economically too for the health systems.
I was going to echo what Ellen said about the unexpected benefit. We have heard from a lot of community health workers that families who had been reluctant to allow them into their homes have been more welcoming of this virtual experience where they get to control what is seen. And it's been such a benefit that it's something that many of them will likely keep as an option moving forward. And yes, with the flexibility about how to serve families, what we found is that in some cases, if you work for a local health department or something, they may dictate which technology you're allowed to use. But for the community-based organizations, they've just asked the family, tell us what you want to use. WhatsApp, Zoom, FaceTime, our staff will learn it. And they have been really, really responsive, and it's been great to see that put into action.
Yeah,
Have you found most people have technology? Sorry.
Yeah, I mean, we definitely found a mixed bag. So with the technology, so most folks have phones, but they don't all have the data agreements that allow us to be on the phone for hours or an hour or whatever that is. So we did morph into a hybrid, kind of a hybrid method now, so that we ask the parents what their preference is. We do go into homes with the appropriate PPE. We take PPE, we take the mask for the parents, so we don't ask them to provide the mask. We make sure they have it, and we do the social distancing. One of the things, as some of you know, we also do home repairs. So we work with the home repair agency, and in reference to what Ellen was talking about, that changed because of the space requirements, right? So the policy in terms of the number of people who can be within a certain distance. So we couldn't have 4 trades at once in the home. We don't have 1 trade at a time. So we had carpentry or plumbing or whatever in there. So that definitely has increased our time in terms of from the start of the repair process to the end of the repair process. But we do home inspections that are hour and a half, because we're looking at structural issues that we've been able to maintain with appropriate PPE and with just 3 or 4 folks at a time. So it's been amazing. Well, not I guess amazing, but remarkable that where there's a will, there's a way. And so the will has been to continue doing what we've all been doing, and we've been able to make a way with some of the urgent flexibility that Ellen was talking about. So I think that just shows that we can, my feeling has always been that where there's a will, we can address some of these social determinants of health that we've all seen, that our programs make a difference, but there just has to be a will, right? There has to be a concerted effort and a concerted determination that we're not going to let these kind of barriers prevent us from really servicing our families. And I think, I'm sorry. I was going to say one more thing. I also have an adult study going on, and what I really see across both studies or programs and studies is the support, the psychosocial support that community health workers are providing in a time where people feel isolated may be the most benefit we're providing with this.
That's
I want to jump in and ask Tyra a question if I could, Kate, which is something Ann and Tyra both said, and I know, Kevin, I've heard you say this before, which is we're seeing less ED and urgent care use for asthma patients. And I think some of us have been concerned during COVID that home conditions are challenging and we might see more exacerbations because people would be in homes that were not necessarily, that had a lot of asthma triggers. And we're kind of seeing the reverse. And I think you had mentioned to me before, you thought, Tyra, that, or Dr. Stevens, that it was better medication compliance because people are really anxious about ending up in the ED or urgent care. But I'm just curious how we reconcile a lot of our work around asthma triggers and reducing them. Now everyone's in their home, but we're starting to seeing less flare-ups.
Yeah, so I think it's probably multifactorial, but if you recall the natural history of hospitalization, emergency room visits, that we have peaks or spikes when kids go back to school and in the winter with the winter viruses. So with social isolation, we've just really cut all of the infectious disease. And we're not only slowed down coronavirus, there's been virtually no flu, no RSV. All those things are triggers for asthma flares. And the one thing that you all know is that what the indoor triggers do is they create a level of inflammation for children who are predisposed to asthma that then gets flared with a respiratory infection. So what I think we're seeing is that social isolation has reduced any exposure to infectious causes. What I'm worried about is that asthma becomes more of a post-pandemic issue than a during pandemic issue, that once they go back to school and having been exposed for over a year at this point to these triggers, that we might start to see, the kind of the thing that we expected with coronavirus. I mean, I hope it doesn't happen, but that's my fear. And I do think early on we saw more of adherence to controlling medications, but now because it's been a year and kids are not having flares, it's probably the opposite, right? That we see folks that we have to convince, yeah, well, maybe you don't take it twice a day, but please take it at least once a day because they're like, my child hasn't had any symptoms since he's been home and it's the school's fault. That's what explains all of this. And now that they're not at school, they don't really have any problems. And so I think this is unprecedented. We're going to see what happens. We can all project or pretend to know, but we really don't. So we'll just have to follow it.
Ann, did you have a comment based on what Ellen was asking?
No, go ahead if you wanted to chime in on that topic. I was going to shift in a different direction.
No, I think that's very true. I guess the question back to Tyra and maybe to you, Ann, would be: do you think that because of this pattern, is there a worry that policymakers might think that there's something different now about asthma management? We need to rethink asthma management because, gosh, we seem to see this reduction and all we did was stay home. Do you think there's a potential worry that people don't understand? I think Dr. Stevens did a wonderful job of explaining. There's a strong connection between these infectious conditions and how it affects the immune system and then what you're exposed to in the environment. There's a very strong relationship that's been understood and nicely explained. But do they understand it? Are the policymakers and the payers going to understand that? What do you think?
Yeah, I mean, I think that when talking to policymakers, we always try to really convey that to manage asthma requires a combination of clinical management and environmental management. And when we're talking about environmental management, we need to look at in-home, in-school, and outdoor environments. And to understand that while one of those might be controlled during this pandemic, there are other pieces as well. And so, maybe this can actually be used as an argument to focus some funding on school environments and really thinking about what are the triggers the kids are facing when they do go back to school, and can we get ahead of that and address those before they all return. So I think we try to turn it into an opportunity to show what a comprehensive approach is needed.
Yeah, I think I definitely faced this question with our home repairs because, we're investing a lot of money in these homes, relatively a lot of money. And, we definitely know that, prior to COVID, we started to see a difference. I mean, with reduction in hospitalization, emergency room visits, but any home of a child we start right now, basically their controls can be pretty good because no one's had hospitalization, emergency room visits, right?
Mm-hmm.
So then your baseline becomes a year of nothing. And then, so post any intervention done, it might actually look a little worse if they go back to school. So I think we have to be prepared for that. I mean, I think the reality is that this is not the norm, and it's probably going to be a couple of years before we see the norm, and we can really talk about this again. And I'm glad that Anne is saying that we can keep policymakers engaged. I mean, I agree with you with schools. The issue with schools is very expensive. One of the things that we're looking at now is just doing IPM exclusion repairs, because we can do that for about the amount that we do for a house. And if we can do that and just there's no more mouse poop on the teacher's desk every day, if we can just take care of that, does that change the outcomes for children? So I think there, it seems to me with asthma, there's always room to grow in terms of environment and clinical med. Like it just doesn't stop. Every time I think we've arrived, we haven't. So it'll be interesting to see.
Mm-hmm.
Well, we certainly found the same with we do home interventions as well, and they didn't slow down. Our housing programs have emergency repairs, and they had important things they had to get into homes, some real hazards that had to be dealt with. So they were right on top of adapting and using PPE and spatially distancing and taking turns going into homes exactly as you described, Dr. Stevens. So they were ready to do it, and that's still an ongoing problem. I still think because the home environment, school environment are so important, that exposure is so important, that even if you go ahead and invest in it, maybe you're not seeing the specific data to show utilization reduction. It's still making the home an environmentally healthier place, if you will, for anyone to spend time. So being preventive or proactive in your effort of home interventions, I think is still a good thing.
Yeah, and I think you can look at quality of life, and you can look at stress, and all of which have been associated with increased asthma flares, and you can see differences that you're making just with those home repairs, right?
Well said. That's exactly right.
And I think we measure kids with asthma, but we really impact the entire family, and that's what I tell myself, at least, as I do this work, that it's not just about that one child, but
it is
about the entire family.
So I see that Kate is back. Yeah, you guys had you guys on.
Never a dull moment, never a dull moment. So I hope you talked about what to do in technology sales. I had the best pivot all set up too, because Ellen had just set it up so beautifully for the next question, but I'm not sure, did you already move into what we've learned about doing the business of environmental health better? Ellen was just talking about urgent flexibility when I dropped off, I'm afraid. Did you guys already talk about this?
We actually ended up talking a little bit about we're seeing sort of a decline in asthma urgent care use, and that was unexpected, and sort of what we think about that. So if you want to tee up the next question, that's fine, Kate. I can comment on what they've said, but I want to make sure you get us to where you want us to go.
Thank you, and I'm very sorry about the internet decided to drop out during this call of all calls. That's how it is. I know. I was going to ask, and I was going to start with you, Ellen, because you've seen so many different domains of action for addressing and the role of the environment in disease generally in this last year. What lessons have you seen develop about how we do the business of environmental health well because of the urgent flexibility we've seen? What have we learned that, we should do this? This makes sense as a moving forward way of thinking about environmental health.
Yeah, a couple things come to mind, and one we've already talked about a lot, so I'm just going to hit the headline, which is really virtual. I mean, that has happened and that is here to stay. I think we all agree on that. It doesn't replace it, but this is now an arrow in our quiver without any doubt. Both telemed, but also the virtual home visit. And I think we're going to get better at that. I think we're still learning that, but there's no doubt in my mind that is here to stay, both in the health world and in the energy world. And I think the learning from both is actually quite interesting.
We've seen one change from that. Our staff have said that families are interested in fewer and less visits. We have a multi-visit model, and with the virtual visits, they're willing to do a couple, but they're not willing to do as many touches as we've done in the past. I'll stop there and leave it at that.
Yeah, and I haven't had as much experience sort of rolling out a community health worker. It's more been that first diagnostic step, and I think they're pretty open to then getting a set of services. From where I sit, I've seen sort of interestingly, and some of this predated the pandemic, but I think it continuing, which is sort of linkages amongst programs. So let me give you a couple of examples. So I had the pleasure to work in Rhode Island, and as COVID was happening, we said, gosh, here it's going to be hot in the summer in Rhode Island. A lot of people are going to be stuck in their homes. We're going to have a lot of high heat exposures, not great for our high-risk asthmatics. So we were pretty quickly able to pivot and bring some cooling to those homes as a new environmental management strategy that's getting paid for out of the environmental management funds, which in this case are grant funds and VW settlement dollars. So they're a little bit flexible. But moving forward, that has sort of opened the door to some partnership between the health and asthma program and the utilities, which are rolling out new strategies around electrification, which, not to nerd out too much, which when you move to electric heat, you also get cooling with heat pumps. And so I think there will be opportunities to see these programs link up. And I was on a call yesterday with a program in Connecticut where we're doing healthy homes and lead hazard repairs and dealing with lead on windows. And the utility said, don't put in double pane. You should be putting in triple pane because we've got climate goals. We'll pay for the windows if you guys do the work, and everyone's going to count the benefits. So both the Rhode Island and the Connecticut example give me this sense that we've been talking about integrating programs and braiding resources for a decade, but with climate goals, there actually are some really interesting opportunities that are coming to play. And the other thing is kind of what you guys, in this linking of programs, I think with COVID, there was this sense that it's really all hands on deck. Everybody has to jump into this. So the wonderful weatherization program Vermont, unlike you guys, which, Tyra said they're still doing home repairs. A lot of the programs I work with really shut down for doing home repairs and just started to open up. And then the second wave really has shut them back down again. So sorry to be a wet blanket, but in my world, that has not been going that great. Anne looks like she's saying also.
Yeah, I mean, I was going to actually raise the question around environmental remediation supplies, because I think as we shared, people have not necessarily been going into the home to do repairs, but as they do the virtual walkthrough where the family has a smartphone, they will notice things that they see or talk with the family about some of their behavior practices, and then be able to provide some of those supplies for remediation, whether that is asthma-friendly or cleaning supplies, some basic pest management supplies. A big one here in California has been the portable air purifiers, given the wildfire smoke. And so I think, again, that's the climate goals combined with the health goals. It's something that we can really do. So I think that the programs have been able to provide a good resource between supplies and education, even in cases where going in and doing repairs doesn't feel either feasible or welcome by the families.
That's exactly right. That's what we're doing. Virtual visits and then dropping off supplies, just as you described. We've had to back off from any kind of in-home interventions. We had them going back in March, but then that's just had to completely taper down just because of the things we've all been talking about. But we've continued the things that you just described exactly.
So
Yeah,
just, I'm sorry, go ahead, Tyler. Go ahead.
we found in our home repair project that from the beginning, it's been really important to actually leverage all of our partners' strengths. So to Ellen's point, we work with different folks with weatherization, work with basic systems repair. We have had, donations. If we're doing a home that's getting to our limit and we still want to put a dehumidifier, we go a different route to get that dehumidifier. So I think even pre-COVID, and that's one thing I will say for our home repairs is that we've really been able to leverage all kinds of partners. And in addition, we've been able to build the economy. We're actually hiring contractors from the neighborhoods we work. So we have a nonprofit who does the training and certification for those one truck contractors so they can then bid on our projects. So we're really trying to make sure that we're not just bringing a program and slapping it on the community, but that it really is organized leveraging of resources that is already there. That's not, we always have money left over in some of these things, and it drives me crazy. And it's just because we're not working together and we're all siloed. So I do think, COVID is really going to help push that forward. And to Ann's point about the supplies, we do the same thing as Kevin says, drop off, but we have been able to get in homes, and some of the hard to reach families, it really is, what can I do to reach them? And our community health workers are amazing. If they really figure out the only way I'm going to get to this person is to go in person, they go in person. And I do, obviously with PPE and everything, and leave it up to them and their families to work out. And we've really been, we've not had any, issues with COVID infections from our interactions with the community members because we know how to do the PPE. And if you think about the hospitals, there's no way we can keep 6 feet away from everyone and still do our job. But once we learned what it took with the PPE and we were able to do that, the hospital infections went way down.
Thank you, guys. I think one of the things I hear in all of you, and this is proven, I think, across COVID, as different health systems and communities have responded, where there are existing strong partnerships across disciplines, say between energy and health, and as there are the places where we have existing programs like strong community health worker home visiting programs with relationships established, we're seeing those health systems were best prepared and quickest to pivot and be effective. And I think that all of the work we've seen to address the determinants of health, I expect we'll see a lot of it carry forward into when we are able to move in and out of buildings and clinics freely again. And I hear you particularly on the telehealth and the virtual access. I wonder, what concerns do you have about developments we've seen during COVID, adaptations, and what concerns you about those adaptations, how they might actually limit our effectiveness in the future? For example, I've heard some concerns that if telehealth were the solution for environmental mitigation at home, we would already have that widespread, for example. So what concerns do you all have moving forward that we might learn lessons that we shouldn't?
Well, we've still seen a huge drop off of we get a lot of referrals, and families are a lot less interested now than they were before COVID. So there's an inherent anxiety related to COVID, but also, not all of them. Our teams have had very good luck with the technology and said it's been good overall, but some don't have that technology, but that doesn't mean they're still all willing to participate. We've seen a huge drop off in that willingness. So we're still trying to bring that back, but that's been a really hard challenge. And then just within our own system, so many of the providers they're focused on the issues that are immediately in front of them, and so they're not immediately thinking of they have already had short period of time with each family or each patient, and now that there's a sort of more of an intense focus, so they're not always thinking about all of the possible options like a referral for home visits or something. So part of it is re-engaging and reminding within our system in the community that options are available. And people say, great, what are the options? Oh, well, we're not actually going to homes yet, but because we've actually had to be very conservative. Infection rates have really, like everybody has said, gone up and down, and we've started to try to get back into homes, and then we've had to back off because the infection rate jumped way up, especially in the communities that we're targeting to try to work with. So it's been very rocky.
Yeah.
It's interesting how I think all communities are different. We actually found, maybe because our community health workers are also in the clinics, that we would have primary care providers reach out to us and say, oh, I know you're not in the office, because initially my team could not be in the clinic for a while. But can you call this mom and do a telehealth and show her how to use the SpaceShare device? So we actually had providers reaching out to us, which made our team feel really good that they hadn't forgotten, which is good. And we have a research project going on now that our goal is to recruit 600 folks, and we were not doing so well right prior to COVID. But actually, a lot of these hard to reach folks we've been able to recruit, and we just, we've enrolled almost 100 kids since COVID, which was unexpected. Totally was not what we expected to happen. But it's because we're reaching out, I think, virtually. We're saying you have a choice. You don't have to have an in-person visit. You just have to have a virtual visit. And so some of these hard to reach families didn't want you coming to their homes, but they were fine with you doing a virtual visit. So I think one question you asked earlier, Kate, like what does that, I think going forward, it'll be interesting to see if we can really characterize what kind of service works the best for. For example, do we make it all by patient choice? Do we say, if you want this, you get this. If you want this, you get this. Or do we say, we know that for, these characteristics, virtual works better, for this in-home works better? I mean, I don't know the answer to that, but that's certainly something that we're thinking about. Like, how do we use what we've learned from virtual visits to inform our next, program or our next project?
We feel like there's going to be a mix of the two.
Yeah, I would say in that same vein, with this wonderful network in New York that I'm working with, we have 3 different hospitals that are going to be trying virtual home visits with their clinicians. And I think one of the things, not only which works for which patients, but like actually how much does it cost to do this in terms of our time and training, and like what is the delivery? I feel like we feel like we're experimenting, and we need to even study the different ways that we roll it out and how effective that feels from the provider side, from the patient side. So we're developing some evaluation tools to try to understand not just asthma outcomes, but outcomes from the experience from the provider side, from the patient side, so that we can really have some deeper learning. Mostly, I think we were rushing it out, right? Get the new product out now. I think everyone's trying to think about, okay, what can we learn from this? I have one unexpected negative thing. It's definitely a negative thing, which is I think sort of the snake oil salesmen are out there. The number of air purifying gadgets, devices that you're just seeing marketed. I just got a query about another one, which I sent to all my favorite industrial hygienists, saying, what do you think? And they all said, no, this doesn't make any sense. Look at the cable, right? So I just, which I thought, but I think it would be helpful if we could find a way to help programs evaluate those kinds of things. Some of those mechanical things, we're moving air better, we're filtering air, but like that makes sense, right? But it's complicated to evaluate those products, and I think that you saw, particularly during wildfires, and some people gravitating to any air purifier they could possibly get their hands on, and indoor air quality monitoring devices. So I think with people spending more time at home, there is this sense, my life feels out of control. I want to control something, so I must be able to control this air I'm breathing here. So I'm a little bit worried about that.
Well, EPA has excellent guidance on portable room air purifiers.
They sure do. They sure do. And Ellen, that's great. And thank you for bringing that up. Some folks in our audience are asking, have we considered the negative impact on asthma of exposures from being stuck indoors. And I think you all talked a little bit about the fact that we're strangely seeing declines in ED visits when I think many of us would have expected all of that home exposure might have triggered something else. But I think what you're saying, Ellen, is really very interesting, that we've got this moment of opportunity. Everyone is recognizing to a heightened degree the value of the indoor environment, but our understanding of what actually works and understanding how to keep ourselves safe. We have some education to grow there. Before we take an audience question and move toward our discussion forum, I want to ask you all to think in really practical terms, really like hands-on practical terms now about things you've learned about the very how-tos of getting environmental trigger management done. And I'm talking like the great lessons you've all shared with me all year that you may not even realize are lessons. Like Kevin, you talked about we got to keep every visit under an hour. And I've heard now you're saying perhaps we even need to think about fewer visits overall. I'm going to start with Anne because Anne, I think you've probably seen more various types of asthma home visiting programs doing things than any of us. And what are some of the secrets of success that you've noted that we should really make sure our audience hears?
Right. Well, as I think about how to adapt the home visits, I think of 4 categories with the programs I need to think through. One is, how are you going to build rapport when you can't sit down face to face with someone in their kitchen? And we talked a bit about that, building trust virtually, sometimes having a brief outdoor masked in-person visit to exchange materials. The second category is really thinking about how to use the technology effectively and being really responsive to what the families want to do. Do they want to talk on the phone? Do they want to use Zoom? Do they want to use WhatsApp, et cetera? The third is then actually doing the environmental assessments where you will guide them and say, okay, and now walk into the bathroom with your smartphone and show me the ceiling and show me behind the toilets. And then turn on the exhaust fans and hold the tissue paper and show the camera so I can see whether it's pulling the air in the right place. But then I think also asking them, are there other things in your home environment that you're concerned about that I didn't ask you to show me? And really hearing that perspective from the families. And then the fourth category is in providing the supplies. And fortunately, this grant program in California that is supporting asthma home visiting programs provides a budget to support that. But I think that it's really important to be able to provide the family with the tools that they can use, combined with their increased knowledge and capacity to control those triggers.
You are muted, Kate.
You're muted,
That was
Kate.
a nice framework, Anne. Thank you. Others?
I think also, a couple of things. One is that training is really important. We've actually hired, a few community health workers during this period. And so what we've found is that we really do need to train them in person. That virtually does not work. So we actually do bring them in for the first 2 weeks, 2 to 4 weeks, depending on the individual for that training. We have been able to shadow, because some of you have heard our step way of training folks, and one part of it is the shadowing before they can be on their own. We do that virtually, and we can do that virtually. But the actual in-person training, the interaction with the senior community health worker, we've just found that, especially when you're teaching asthma self-management pieces, that works most better in person. And there's ways to do it that everyone's safe, so it's not a question of exposing folks. And then the other thing that I'll say, I think that it's important to realize that the intangible stuff might be one of the most important things that you're doing, and don't underestimate what the community health workers are providing in terms of psychosocial support, and B, what the strain may be on them and how to do community. And it's hard. I mean, I'm not saying we perfected this, but how do you do team building kinds of activities even in light of this virtual existence? So I think it's important to remember that as you're doing these programs. And given giving the community health workers voice to, to actually come up with their own solutions when there are problems.
Well, what I would add is our staff has found, like Kate hinted at, that we've got to keep the assessment short and concise, but they've learned to rethink how they interact with the families because they have the camera, they have the control, to start with asking about their concerns, start with asking anything they want and feel comfortable talking about. And then they've really learned to be carefully nuancing how to get the information they want, rather than say, go to the bathroom or go to this place. Have the family lead, but then while we're in that room or while we're talking about that concern, well, let's look at these other issues and let's take an opportunity to look at this. The other thing they have found that has been surprising is there are many things that families really haven't looked at closely before, like their own furnace or air handling system, or maybe they haven't looked at as closely as their room air purifiers. We may want to, and it's an opportunity for, we have to ask them to touch something or grab something and explain what that is to be able to look at it or inspect it or talk about it. And it's been an educational experience for the families, because now they're learning about these things because they have to direct the activity as you move through the home. And that has been we've gotten some good positive reviews from them. Oh, I didn't know about that, or I didn't know that this was supposed to do that. So it's been very eye-opening in that way. I also want to mention that we use interpreter services through the hospital, and with virtual, in the past, they could go with us, or we might have them on the phone, so it might not be as effective, but they're able to join on a virtual assessment, and that actually has worked very well to be able to use them with some of the families where English isn't their standard language.
So I'll just offer two real quick things, Kate. One is I think one thing that we've learned is that clinicians really need to understand billing codes better. There's a lot of opportunity to use different ones, and as with this urgent flexibility and telehealth, just a couple of the hospitals in New York have some expertise and have shared that with others, and that's been incredibly helpful. Once they sort of know how to code stuff, it turns out there's more stuff reimbursable than you might have thought, but some stuff isn't. So I don't want to be overly positive, but it's worth sort of really getting into that. So see Dr. Stevens laughing at me, which is fine. And the other thing that I have noticed is everyone is starting to get social determinants of health. So the Weatherization Program Vermont, which I, again, adore, and I'm talking to you from Vermont today, they were totally shut down during COVID. And we said, hey, you know what? You have a relationship with your clients. They really trust you. They like you, serve like 1,000 people a year. Your staff is sitting at home and they're really kind of bored. Your energy auditors, can't we give them something to do? So they called all their past clients and said, we had a couple of questions, can we help you with? And the one that comes up over and over again is food, honestly. It's just coming up everywhere. So for every asthma visit, people are asking about food. For every weatherization visit, we're asking about food. Food is a universal, and it is now getting added to almost every one of these. And the client base, when we asked about social determinants of health, and that included respiratory, we also had some questions related to COVID to make sure they were connected to resources. I would say the energy coaches who did it, and this is to Tara's point, felt better about their jobs, right? Like it was very satisfying. Someone said, wow, I'm so glad you called. I was actually confused about this. Where do I go for that? And they just asked 3 or 4 questions. It was great. But social determinants, I think, is a language where people beyond us are speaking and understanding. And
Finally, yeah.
It's so that to me, when you have energy programs saying to me, hey, let's ask about food, because it's a social determinant of health, I go, wow, we're in a new day.
Yep.
Very true.
I think that is a terrific spot for us to end on. And yeah, I think that's absolutely true. And we're all going to charge forward and provide all these proven technical solutions we know for addressing those environmental determinants of health. Thank you all for your time. It is a gift. We appreciate you so much. The panelists, I want you to know the audience is eagerly asking if you can share some of your tools, your templates, any technology or home visit information you have. And I'm eager to tell them, yes, come to the Asthma Community Network. And when we move our discussion forum there, after the forum, explore, and you will find many of this group's tools already there. Also, we will post after we get this recording posted, and we'll provide resources there as well. I'm going to ask if Pierce, you can take over and move us, only because there's so many good questions that have come in from the audience. I think we're going to be quicker at divvying them up and answering them in the forum than if we take them here as a group. So I'm going to turn over to Pierce now and say again, thank you, dear panel. And sorry for dropping out on you in the middle. I'm glad you handled it like pros, as we knew you would. Thank you.
Thank you.
Thank you all.